So yeah, today I'll be talking about osteoporosis, and I'd like to begin with a brief description of a good friend of mine who recently died a couple years ago, Christina Apo from the village of Taquaral. She's a Jumaane woman. Her age at death was 94, and so she's one of the oldest, if not the oldest, Jumaane that we've ever known. And I first met her in 2004, and she walked upright. She did not have this condition, what we call kyphosis. So this is resulting from basically compression fracture of thoracic vertebrae, probably also spinal osteoarthritis. And this condition in general is not so rare among the Jumaane for individuals that survive to old age. And there are a lot of individuals that survive to old age. And so because it's not so rare, it sort of gives us a little bit of insight in subsistence level physically active societies, the extent to which we should expect to see sort of degenerative musculoskeletal conditions, whether they're in fact mismatched diseases or not. And so I'll sort of recurrently come back to this question: is osteoporosis and perhaps other musculoskeletal diseases, are they considered mismatched diseases, given what we know from pre-industrial small-scale societies? Just to give you a sense of the burden of osteoporosis, I live in Europe, and so just to give you some local flavor, but also some of the best data that we have actually come from Europe on this topic. And so there's quite a high burden of osteoporosis-related fracture. And so here you could just see the estimated number of, these are incident fractures by type and country. You could see some of the most common fractures are of the hip, vertebrae, and forearm. If you look at some bones like the hip, there appears to be a north-south gradient where fracture risk is higher in Northern Europe, and as one goes south, it appears to decline, and some people have hypothesized that this is linked to sunlight exposure, vitamin D deficiency, and other things. It's not so apparent just looking at all pooled incident fractures. So Europe has some of the highest fracture rates in the world. About a third of all incident fractures occur in Europe, 3.5 million per year. Basically, the population of Texas, about 30 million people in the European Union in this age range have osteoporosis. You could see it contributes quite a high percent of all the global burden of non-communicable diseases just within Europe, and it has massive costs linked to treating incident fractures and long-term care. So osteoporosis perhaps fits the definition of a mismatch disease in the sense that if in fact it's more prevalent now than it was relative to past populations, it may suggest that our human bodies are not particularly well adapted to many of the conditions that we face in modern societies. And so you can see, to my knowledge, there are only two studies that look at secular trends in the incidence of fractures, one in the US, so these are data from Minnesota, the other in Sweden, and they both show fairly similar things. So here we're just looking at vertebral fracture, and we might expect a few things if in fact osteoporosis is a mismatched disease. So one, is it more prevalent now versus past populations? So notice, obviously, we're not going very far back into time. Obviously, we want to make comparisons between hunter-gatherers versus the present, but these are the best data that we have at the moment. And in addition to prevalence, we might expect that if it is in fact a mismatch disease, it may be occurring at younger ages now. And so if you partition the sample, you can see relatively no change in vertebral fracture incidence among some of the youngest people in the sample, suggesting it may in fact not be occurring at younger ages. But if you look at some of the older individuals in the sample, and so these are data from the Mayo Clinic and surrounding private areas, and there happens to be fantastic data over this 40-year period, you do see a slight increase among some of the older individuals. But what's driving most of this increase is postmenopausal women suffering from moderate to severe trauma as opposed to mild trauma. Okay, so perhaps some indication that prevalence is increasing where the data do exist. Now, of course, the world's population is aging. If in fact osteoporotic fracture is increasing over time, this is going to be a growing problem. Okay. And one of the issues with osteoporosis is, in fact, that most new fractures are not treated. And so you can see some prospective cohort data across various different countries, following treatment-naive participants at baseline, and then following them over the course of several years. And you can see here that women, in particular women that suffered any fracture as they were followed over time, so of this sample of 60,000 women, within a year, 1,000 suffered any type of fracture. Only 17% received anti-osteoporosis medication the following year of experiencing fracture. So over 80% of individuals that experience fracture are actually not getting treatment. And this is just looking at people that get a fracture. It's not looking at people that don't get fractures but are eligible for receiving medication because they have high fracture risk, because they may have osteoporosis. So a lot of untreated fractures. And when we think about osteoporosis medication, we can think about anabolic agents, so stuff that basically adds bone. And then we can also think about a different class, agents that inhibit bone resorption. Okay. Of those that do receive treatment, roughly half of people discontinue their treatment within a year. Okay. It's not well known why there's not such high persistence. People may be worried about adverse side effects. It's been reported that there's a risk of osteonecrosis of the jaw, for example, for some of these medications. But a very substantive percentage of individuals that do receive treatment discontinue it, and uptake appears to be decreasing over time. So all of this is worrisome. So despite this large treatment gap, despite relatively poor uptake in treatment, most clinical osteoporosis trials are actually focusing on treatment, not prevention. The National Osteoporosis Foundation has identified various priority areas for reducing the burden of osteoporosis, one of which is to maximize peak bone mass. So obviously this is occurring earlier in life. And yet a lot of these trials are focusing on treatment rather than prevention, and many are actually excluding older individuals. And so this is a problem. So I want to tell you what the remainder of the talk will look like. We can think about osteoporosis as sort of the end point of a process that begins much earlier in life, or fracture as the end point resulting from a process that occurs much earlier in life. So bone mass begins to decline in the early 30s for men and women. So I'm going to be talking about both human skeletal gracility and osteoporosis, and you can see some of the definitions for each of these terms down here. After talking about how humans may be uniquely gracile relative to other great apes and other species, and discussing some of the implications of this gracility with respect to our health, I'm going to introduce some common explanations of modern human skeletal gracility, which focus on physical activity, sedentary lifestyle, then introduce some of the knowledge gaps of osteoporosis from the perspective of evolutionary medicine. So the fact that there are various inconsistent findings based on these common explanations of modern human skeletal gracility. Physical activity is so important for maximizing bone mass and maintaining peak bone mass. We actually find evidence that may contradict this, the importance of physical activity, or at least suggest that they're really important moderators. Also, I want to briefly discuss some study limitations of existing tests of these models of physical activity on human skeletal gracility, talk about some mixed evidence and missing data, okay? And then discuss some of the initiatives we've been conducting among the Jumaane, focusing on both between and within population analyses. We study various bones using various methods, so I'll be jumping around from one bone to another. And so you can see some of the bones that we've been focusing on, some of the methods that we've been focusing on to study those bones and how they change over time and by sex and with other lifestyle conditions. I'll briefly discuss some new initiatives and then conclude. Okay, so bipedality obviously has some fitness advantages, but a lot of these advantages come at a cost. So basically, if you look at most four-legged vertebrates, they have vertebrae that are neatly spaced and stacked. But once you shift basic locomotor system to standing upright, we have all kinds of problems linked to our flexible spines. So added stress on the vertebrae themselves and the legs themselves. So there are other human adaptations linked to our joints. Our joints have expanded to accommodate these novel forces. And so when you expand joints and you have this flexible spine, it can lead to a lot of mechanical wear and tear that makes us susceptible to things that other animals aren't susceptible to, osteoarthritis, perhaps osteoporosis and other conditions. So there are these downstream effects on our joints. Intervertebral disc narrowing is another, or slip discs, when arches on the foot become collapsed. So various problems, and some of these problems are directly relevant for major life history events, things like childbirth. So there's lots of shearing stresses on lumbar vertebrae as a result of bipedality that could be avoided using other forms of locomotion. And a lot of these, and so women have adaptations to deal with these shearing stresses by adding a third lumbar vertebrae to accommodate some of these new costs. But despite these adaptations, it leads to tremendous back pain in the case of pregnancy and the shearing stresses on the vertebrae. And you can see that low back pain ranks number one in terms of years lived with disability worldwide. It's the number one cause of activity limitation, work absence. In the medical community, it's often diagnosed as nonspecific, which basically means we don't know what the cause is. And so it's not due to acute trauma or to other obvious structural failure. So humans face a lot of relatively unique problems that musculoskeletal problems that other organisms don't face. Now, if you look at captive or wild great apes, there is to date no evidence that spontaneous osteoporosis-related fracture exists. So here you could see bone volume fraction across various great apes. So this is looking at the 8th thoracic vertebrae using micro-CT. Micro-CT is very nice because you can partition individual vertebrae into the vertebral shell, but also into the trabecular bone. And most of the vertebrae is composed of trabecular bone. And you can see whether you're looking at bone volume fraction, humans have relatively low values compared to the other great apes. And if you look at vertebral shell thickness, you could see that humans have relatively low values, taking into account body size. Okay, and so these low values increase our risk of experiencing vertebral fracture. The 8th thoracic vertebrae is important. It's at the center of this kyphotic region that we saw earlier in the picture of Christina. And so these differences between humans and other species are not just limited to the spine. We see them elsewhere in calcaneus, femoral neck, femoral head, metatarsals. And you also see differences in the upper limbs as well. So humans have relatively low bone volume across all these skeletal sites, even after taking into account various things. Now, this is not to say that these other great apes aren't losing bone with age. They are, in fact, losing bone with age. But it appears that the process of bone loss in non-humans is quite different in the sense that most bone loss is limited to cortical bone, so the hard, compact bone, not to the metabolically active trabecular bone. So most of the osteoporotic fractures that humans get in the hip, in the spine, occurs in areas of high trabecular bone, okay? So great apes are losing a lot of cortical bone, not trabecular bone. And also, great apes, most great apes like chimpanzees, they start off with more bone to begin with. So even if there is some loss, the loss is less likely to lead to fracture, okay? So there have been some cases documented of chimpanzees, for example, with osteoporosis, but the critical difference is that osteoporosis is not necessarily linked to fracture as it is in humans. And so we can then compare humans and our close chimpanzee relatives to ask the question of when we begin to see the emergence of modern human skeletal gracility. And so there's been some recent work basically suggesting that we see these differences, that human skeletal gracility essentially emerged in the Holocene. So you really don't see, whether you're comparing the epiphyses of femur, tibia, metatarsal looking at trabecular bone fraction, and there are similar results looking at some cortical bone, both lower and upper limb, although results seem to be more consistent for the lower limb. You really don't see any significant differences between humans and chimpanzees until the Holocene, okay? And so then we can ask, well, within the human lineage, when do we begin to see this decline in bone strength? Well, it appears that the Neolithic, so around the time of 7,000 to 4,000 BP, during the Neolithic revolution, there appeared to have been a dramatic decline in bone strength. So here we're looking at femoral anteroposterior strength. So using the midshaft section modulus as an indicator of bending strength. I'll talk a little bit about this, but basically using bone cross-sectional geometry to try to understand how rigid bone is when force is applied. And so you can see a decline in the Neolithic that continues right around until the Iron or Roman period, and then you see sort of a leveling off. So really no change in this femoral or tibial AP strength in the last 2,000 years. So despite increasing mechanization in the last 2,000 years, despite increasing urbanization in the last 2,000 years, there don't appear to be really dramatic differences in bone strength in the last 2,000 years, but something is going on around the Neolithic when humans are really producing a lot more food with agriculture, intensifying agricultural production, and there are a suite of social changes happening as well. So here's a sort of a very simple common conceptual model and a hypothesis to explain the emergence of human skeletal gracility. The humans are less active versus other hominoids and extinct hominids, and this decline in physical activity is what's producing skeletal gracility. And so here you have the intensification of agriculture around the Neolithic, linked to greater reliance on tools. So basically, rather than using our muscles, so if you think about what's straining, loading bone, ground reaction forces and muscle forces are the two primary things that are loading bone, and you need this loading for bone to respond and to grow. And so humans are essentially substituting muscle loads with extrasomatic stuff, the tools that they're making. And so you have these bidirectional relationships between agriculture and tool use. And of course, intensifying agriculture is linked to changes in social organization and sedentism. And again, we know this by focused analyses of lower limb, which presumably reflect physical activity levels. And so you have the combination of tool use and increased sedentism associated with agriculture contributing to less activity in bone loading, which is then perhaps causing skeletal gracility. And so one can derive various predictions from this common hypothesis of the importance of physical activity. Higher activity in childhood, early adulthood results in higher peak bone mass, less age-related bone loss, less risk of osteoporosis-related fracture. So this is the common model that's been tested for decades and even longer than this, okay? And so one of the things that I'm trying to do with my research is expand this model, not to sort of dismiss the importance of physical activity. Of course, we know it's important, but to also consider some of the mediators and some of the moderators of this relationship between physical activity and human skeletal gracility. And so basically all we're doing is adding this stuff here. So these are things that we can actually directly observe among the Jumaane or other small-scale modern subsistence populations. And we know each one of these things may have some effect on human bone structure. So I don't have time to go into each one of these, but we know there's lots of evidence suggesting that increased population densities linked to sedentism may increase levels of infection and epidemics. And we know that there are both direct and indirect effects of infection and inflammation on the human skeleton. Of course, the increased caloric production that's happening with agriculture is affecting our diet, which has obvious effects on bone structure. So perhaps decreasing dietary diversity, more susceptibility to famine, that's all linked to agriculture, may not actually be so good or osteogenic, I suppose I should say. And this increased caloric surplus may actually accelerate rates of puberty and production of sex steroid hormones, which has independent effects on bone mass, and fertility. Okay, so if there are trade-offs between investment in reproduction and maintenance, then we may expect that increased fertility may actually be associated with reduced bone mineral density or whatever indicator of skeletal robusticity that we're looking at. So I'll be returning to some of the results that we find related to this model. Okay, but for the time being, just to focus on this relationship between physical activity level and bone strength, it's obvious that sedentary lifestyle clearly contributes to osteoporosis, low bone mass, osteoporosis-related fracture. Much of what we know is coming from weird populations. I'll talk about this in a second. But basically, many people that study bone use models that have been developed in mechanical engineering that look at essentially bones as supportive structures as an engineer would look at a building. So the beam model. And so you can see, I was just in Barcelona with my family last week, and you can see one of the famous buildings designed by Gaudi. And you can see actually how it quite nicely resembles trabecular bone and differences between normal and osteoporotic trabecular bone. So you have these struts that are there functioning to support the body. And these struts can decay over time. And so one can apply techniques that physicists, mechanical engineers have developed in trying to understand strength in buildings to bone, okay? And so frequently how this is done is to try to look at the loads. So that's what these black arrows represent. Loads applied to bone. And again, most of these loads are coming from muscle attachments or ground reaction forces. And there are various types of loads. And each of these different loads produce various strains. And so the idea is that bone is a dynamic, responsive tissue that can redistribute its own tissue in response to the direction of the highest bending strain. Okay, so if there's constant force applied to one side of a bone, bone can respond to add more bone tissue to that given side to increase its structure and its rigidity. So bone is constantly, once the adult skeleton is fully formed, bone is constantly adding tissue, taking tissue away. So it's this constant process of bone formation and bone resorption. And really when we begin to see bone loss in the early 30s, and this accelerates over time, what's happening is the rate of resorption, the rate of taking bone away, is outpacing the rate of bone formation, okay? So again, there are diverse lines of support for this model of physical activity level, the extent to which physical activity level affects bone structure. A lot of this research comes from non-human animal models where these poor mice and rats get forced onto treadmills, and then we can examine how their lower limb bones respond to bipedal walking. Lots of other evidence, randomized controlled trials, for example. So here you could see a meta-analysis, the effect of impact exercise on femoral neck bone mineral density among postmenopausal women, and studies of competitive athletes. So these are sort of the three domains from where much of our knowledge comes from this idea of the tests of models of bone functional adaptation, this idea that bone is responding in adaptive structural ways to these forces. So here you could see a male tennis player, and you can see this is the hand. So we're looking at the humerus going from proximal to distal. So here you could see the hand where he holds his tennis racket compared to his other hand. And you can basically see, it's probably easier if you rotate the image 90 degrees. But basically what you see is that bone is responding to playing tennis by increasing its area, its medullary area, its cortical area, not necessarily by adding bone mineral density, okay? So these are our main tests of these models of bone functional adaptation. Now there are some caveats. We don't always find support for these models of bone functional adaptation, and there are also some animals who don't really see, where we don't really see the effects that we might expect if we were taking a strong view of bone functional adaptation. So animals that hibernate, where there's lots of physical inactivity, we don't necessarily see that much bone loss during the period of hibernation. And if we do, bone is rapidly gained right after the period of hibernation. So people have looked to biochemically what's happening with respect to bone metabolism in these model species, whether it's bears or ground squirrels, to try to gain some insight into what's happening with humans. In the human case, there are some really well-known effects. What happens when you go, for example, into space as a NASA astronaut, where the interesting thing about zero gravity is that there's really no loading on bone, and you can see pretty substantial declines in bone mineral density at various places in the body. So this is the percent change per month. And these are quite substantive declines. Your typical space flight is lasting 6-7 months. So, if the spine weighs, let's say, 100 grams in a 6-7 month space flight, you can lose something like 10 grams out of your spine, which has obvious implications. And so, of course, NASA is keenly aware of this and tries to figure out ways in which they can encourage astronauts to exercise. And in fact, there are some very effective ways that astronauts can be avoiding bone loss, but it appears to require lots of force. Okay. So, again, much of the knowledge base is coming from competitive athletes, non-human animal models, these sort of weird settings, weird societies, or astronauts or competitive athletes. In anthropology, a lot of the what we know is coming from bioarchaeological studies of bone functional adaptation, and they've taught us quite a lot. And in fact, one should be quite impressed with the amount that one can gain just by simply looking at a bone in terms of trying to reconstruct lifestyles and physical activity levels, and other aspects of life, diet, parasitism, just from bone. But there are some limitations. Obviously, we can't directly observe behavior. We can't necessarily observe many other lifestyle features linked to diet, linked to the pathogen exposure, etc. In many cases, samples often span thousands of years, and we know that there are climatic and there are other events that are happening over the course of these thousands of years, and yet it's sort of just treated as one point in time to compare to another point in time, issues with imprecise ages, etc. So a lot of tests of these types of predictions are done often in these bioarchaeological contexts. But I want to take some of these limitations into account. And there are some other limitations that we see. So in some cases, we don't really find much evidence that differences in femoral stiffness or femoral strength emerge if we were to just compare agriculturalists versus pre-agriculturalists. And we might expect differences between these populations based on the simple model of bone functional adaptation, but we don't really find any effects. One thing to consider is that children's activity budgets, so children can do a lot more in agricultural versus hunting and gathering societies in terms of work. And so if childhood is really, and the developmental period is really a critical time, and we know it is, during which bone is being formed and peak bone mass is being maximized, then we may not necessarily expect huge differences if children are physically active in agricultural versus these other societies. Some of our earlier work actually finds, one of the things about the Jumaane project is we have behavioral observation data on individuals early in life, and then we can measure their bone structure using ultrasound here later in life. So basically what we're plotting here is individuals in the upper quartile of time spent doing various activities, and comparing their bone stiffness to other individuals, so upper quartile versus everybody else. And you can actually see that once you control for anthropometrics, fat-free mass, age, etc., sex, once you control for a lot of things, people who do spend more time in horticulture actually have higher radial, so SOS is just speed of sound, it's a measure of bone rigidity. Higher values mean stiffer bone. Higher radial stiffness relative to all other individuals. And we don't see any real consistent effects of time spent hunting on either radial or tibial stiffness. In fact, none of these activities, so participation in any of these activities does not predict tibial stiffness later in life. And so we we may want to think about this and perhaps exercise some caution. If you don't find in the archaeological record differences between populations, it may not necessarily be indicative of differences in physical activity level. Various other knowledge gaps, just physical activity level, we know varies tremendously even within subsistence regimes, so comparing farmers to hunter-gatherers. It's not even so clear that there are differences between these two groups in how much physical activity that they're actually doing. And perhaps most importantly, from the mismatch perspective, it's unclear whether osteoporotic fractures were prevalent over human history. A lot of people, and this continues today, argue that these fractures were relatively rare over human history, but we lack systematic population level data, and this coupled with the fact that there are some other issues with interpreting bioarchaeological remains, I think we should be a little bit cautious before we make the conclusion that osteoporosis was rare over human history. So in the time that I have remaining, I wanted to discuss some of the things that we've done and that we're doing among the Jumaane, going back to this basic question, is osteoporosis a mismatched disease? And again, so here's a quote from Dan Lieberman in his 2013 book, The Human Body. Osteoporosis was rare among the elderly until recently. We're going to revisit this question by actually looking at prevalence of osteoporosis-related fracture among the Jumaane. We can ask these other questions. Is it more severe now than in the past? Is it occurring at younger ages now? And so one of the first things that we did, and again, I want to emphasize we're using really crude technology. We're using bone ultrasound. This is by no means a gold standard way to assess bone strength and rigidity, but at the time, it was the best that we could do in the field. So here we're just measuring calcaneal. We're using calcaneal ultrasound to measure calcaneal stiffness. So basically, you have an ultrasound wave that passes from one side to the other, and you can measure in meters per second the speed at which waves pass through bone, and higher values represent stiffer bone. And we have reference samples where we can compare Jumaane values versus age and sex-matched American values, so that's what we're doing here. So this sample is just looking at women from the ages of 15 to 75. And so if you just look at women and compare American versus Jumaane values, you could see that at every age, Jumaane have much lower calcaneal estimated bone mineral density. And as you get older, these differences magnify. Okay, so just looking at the proportion of the maximum, you could see 20 to 29 is the period of peak bone stiffness in the calcaneus. And here's what's happening with age. By age 75, Jumaane are only at something like 57% of the adult maximum, whereas American women are about 75%. So lower values overall at all ages, and perhaps, this is a cross-sectional sample, but perhaps greater age-related decline among the Jumaane. So all else equal, this is the opposite of what we may expect from the strict interpretation of the bone functional adaptation model. Jumaane are much more physically active than Americans. They're beginning their activities at a much younger age. And so, it's obvious that physical activity is important, but other things are important too. And so we're trying to explore what those other things may be. Well, one of the obvious things may be fertility levels, okay? And so here you see a typical Jumaane family. So I'm sure you've all heard many times from Ben. Jumaane total fertility rates are 9 births per woman. So this is one family. And so we may, for theoretical reasons and for other epidemiological reasons, we may expect trade-offs between investment in statural growth and maintenance versus reproduction. And so one might expect that higher fertility may be associated with reduced calcaneal stiffness, and in fact this is what we find. So it doesn't really matter if you look at premenopausal women or postmenopausal women, although there are some very important differences. But basically, if you were to compare women in the high parity category and you compare women in the lowest parity category, it's about a 1 standard deviation difference for both pre- and postmenopausal women. Okay, so high fertility may be one reason why, despite their high levels of physical activity, Jumaane women appear to have reduced calcaneal stiffness relative to American women. So again, because bone ultrasound isn't the gold standard, perhaps best way to measure bone, I was a little bit nervous and worried about the accuracy, the validity of the results that we were getting from this clunky old ultrasound machine, which had constant power interruptions in the field. And so perhaps, I'm sure you've already heard about our initiative among the Jumaane to do CT scanning among the older adult population. And so we've been doing a combination of brain and thoracic computed tomography scans among pretty much everybody over the age of 45. It's a population representative sample. We have over 85% coverage. And one of the things about, so we were motivated in doing this because we wanted to look at the heart and the arteries surrounding the heart. But what's nice is that the vertebrae also appear in the field of view. And one can estimate, using various algorithms, you can estimate bone mineral density of thoracic vertebrae from these CT scans. And so this is what we're doing, looking here at just T7 to T10. So you can identify an ROI, a region of interest within. You can pick these three vertebrae here, and then pick the middle, basically, of each one, and then take the average, and then use that as the bone mineral density value. And so we basically did a comparison using identical methods from the same laboratory, comparing the Jumaane bone mineral density values. Now we're not looking at the calcaneus, but now at the thoracic spine, comparing Jumaane to Americans. And we see similar patterns for women. Okay, you see that values are lower, perhaps not of the same not of the same magnitude as the calcaneus, but values are lower, and values are declining with age. And if you age standardize, you can see the age standardized difference for the whole sample. But for men, you don't really see a difference. Okay, so this difference between Jumaane and American only appears to be for women. And again, so we were thinking that fertility may be one of the reasons underlying this. And indeed, we do find the same parity effect, such that high parity women have lower thoracic bone mineral density. But if you include other indicators of fertility, so when women begin reproduction, so we just did a median split, whether women have their first birth before 18 or after 18, we find a significant effect such that women who give birth before 18 have lower BMD in the thoracic spine, and women with long interbirth intervals have higher values. Okay, and so lactation. One of the things that's happening in lactation and the production of breast milk is, especially in populations that have low calcium intake, like the Jumaane. So Jumaane have something like 300 milligrams per day, which is about a third of what the FDA recommends. So basically, during lactation, Jumaane women are sucking calcium out of their spine, or out of their body skeleton, which is a huge reservoir for calcium, especially if they're not replenishing it in the diet, converting it into breast milk. But they're not able to fully replenish, especially if IBI is relatively short. Okay, so we see sort of these, and when you include both age of first birth and IBI in a model, they're both significant, and their interaction is significant, and the effect of parity actually drops out. Again, this is pointing to fertility as one of the underlying differences between populations that may be implicated in explaining these differences in skeletal robusticity. We also find effects of parasitism, or at least high infectious exposures. So individuals that have, in this case, repeatedly high white blood cell counts over time. So one of the things we're doing is monitoring white blood cell counts for individuals and doing this over time. And they're strongly correlated within individuals over time. So people that have a high white blood cell count at time 1 often have a high count at time 2. And you can see that those with persistently low levels, so less infection, have higher calcaneal bone mineral density once you take into account some other factors. And this is about a 10% difference. Consistent with a lot of other studies that link infectious exposures to reduced bone mass. But this cannot really explain the data that we're finding where men, Jumaane men and American men aren't really different in terms of their thoracic spine. We only see these sex-specific effects. One of the things that may be going on, I've been focusing on bone mineral density, but again, because bone can be redistributing tissue in structurally adaptive ways. Bone mass is only one route to stiffer bone. A bone can also redistribute its tissue, even at low bone mass, and that redistribution may be protective, okay, in terms of reducing fracture risk, et cetera. And so here's something that we find fairly consistently in America, looking at cadaver samples. You begin with age, you see an increase in medullary area, so an expansion of the medullary area for both sexes. But one of the interesting things is the sex difference where you basically don't see any age-related change for men. So bone is being added roughly at the same rate that it's being taken away, but you see a decline for women in cortical area, okay? And so this is basically what is happening in these weird populations with age. You begin to see, this is the medullary area, schematic, what's happening with age. You begin to see this expansion in both sexes. But if you just look at the cortical area, it's staying relatively similar, or it might even be expanding slightly for men, whereas for women, cortical area is going down. Okay, so this is a weaker bone than this. If you were to, again, going back to the cylinder mechanical engineering analogy, if you had these two cylinders and you rolled them down a ramp, which one would go faster down the ramp? This one or this one? Well, I'll tell you, it's this one. Yeah, so this is going to be a stronger bone than this one, and this may be one reason why women in Western societies may be more susceptible to fracture with age, because their bone is not compensating in the same way that it is for men in terms of making these structural adaptations. What's interesting is that we don't see such a sex difference in pre-industrial societies. So in pre-industrial societies, using this Pecos Pueblo sample that did a combination of hunting and gathering and agriculture, a little bit of agriculture. Again, you see the same increase in medullary area with age for both sexes. But if you look at the cortical area, it's relatively constant with age, okay, for both sexes. And remember, with the US, it declined for women and basically stayed flat for men. So for women, it's basically flat here. And this part, this is just the sum of the cortical and the medullary area. So it's basically going up with age for both sexes. And so people have suggested in these high physical activity level populations, there may be these compensatory bone responses that happen with age. Even as age-related bone loss is occurring, bone may be redistributing its tissue to protect against fracture. So we want to begin to explore this possibility among the Jumaane, knowing that they have high rate of bone loss with age and low bone mass to begin with compared to the U.S. population, whether we use the ultrasound or whether we use the CT technology, particularly for women. And so we're beginning to look at vertebral deformity. Okay, now some might call this vertebral fracture. But there's a lot of contention in the medical community about what constitutes a fracture, how much deformity is needed to consider it a fracture, and there are different techniques, et cetera. And so what we're trying to do now is using the thoracic CT data is grade individuals by the extent of deformity that we see. So we can consider mild, moderate, and severe. And so basically what we're doing for a given vertebrae is assessing whether there's a 20 to 25% reduction in height. So this could be anterior, in the anterior plane, posterior plane, or in the middle. And if so we have physician readers reading these data, and if you see 20 to 25% reduction in any of these different planes, coupled with some loss in bone area, we call it a mild deformity, and you can see the values for both moderate and severe deformity. So we can determine which individuals have vertebral deformity or perhaps vertebral fracture among the Jumaane, and then compare their values to other populations using the same method. And remember the contention that's motivating a lot of these analyses. It's often claimed that osteoporosis-related fracture is really rare over human history. And so if that's the case, and I'm not saying that Jumaane are living fossils or even perhaps representative of the broad mosaic of human evolutionary history, given all the different habitats that humans have survived in, But we may expect, all else equal, testing models of bone functional adaptation, we may expect much, much lower rates of vertebral deformity among Jumaane versus these other populations. Even if their bone mass may be lower, we may expect these structural adaptations, this redistribution of bone tissue, to compensate for this age-related bone loss, and which may result in reduced fracture risk for Jumaane. So we're beginning to test this. And these are some relatively new data, so my apologies if some of the data analyses are underdeveloped. So basically what we're doing right now is just comparing Jumaane thoracic vertebrae 6 to 12 and asking whether a fracture is present in any of these vertebrae. And an individual gets a 1 if there's a fracture present and a 0 if there's no fracture present. And we're, in this figure, just comparing Jumaane men versus Jumaane women. You could see it's a fairly large sample size for this type of study. And I mentioned earlier that there was a lot of contention about how much deformity is enough to constitute a fracture. And basically, I don't want to get too into this debate, but the results suggest that it doesn't matter. Basically, Jumaane men have higher fracture risk than Jumaane women, whether you're using this less severe threshold, greater than or equal to 1, or whether you're using the more severe threshold, so you're only counting a 2 or a 3, so the moderate or severe fracture. And in fact, if you use this more conservative measure, so only moderate or severe, you're not including mild fracture as fracture, it doesn't really matter. But the relative risks you'll see when we look at the population comparisons actually magnify, actually strengthen. Here, not so much. But basically what you can see is that Jumaane men have much higher fracture risk in the thoracic vertebral spine or vertebral deformity than Jumaane women. And so this was kind of a puzzling finding given the bone mineral density values that I showed you earlier, where there are no differences between Jumaane men and American men, but substantial differences between population level differences for women. So if we just compare looking at Jumaane women only, those women that have any vertebral deformity versus those women that have no deformity, you can basically see that there are no systematic differences in anthropometrics. Women with deformity aren't much older, they're not shorter, lighter, they have less body fat. What we really see, though, is that there are big differences in thoracic bone mineral density, which perhaps isn't surprising. And also, higher parity women are more likely to have vertebral deformity, and those women with vertebral deformity have faster interbirth intervals. No effects of modernization, whether it's proxied by Spanish, fluency, proximity to market, or number of years of schooling. So it's really BMD and indicators of fertility that are associated with vertebral deformity. Okay, if we do a similar analysis or comparison among just Jumaane men, comparing men with any evidence of deformity versus no deformity, one of the things that's interesting is you actually don't see any difference in bone mineral density among men with versus without deformity. And if you run a regression, doesn't really matter what you control for, what type of regression that you do. Thoracic bone mineral density is not a predictor of whether men have any vertebral deformity. What we do see, though, is that men with deformity are shorter, but actually have higher BMI because they have more body fat. But other proxies of modernization we don't see any significant differences between these groups. And so if you ask now the question, comparing Jumaane women versus American women, so here we're looking at population representative American sample from the MESA study. So lots of individuals in the MESA study get a chest CT scan. And we're combining these data with local data from an LA clinic. And this is the same lab that analyzed these data, is also analyzing the Jumaane data, so using identical methods. and doing the same type of comparison, comparing Jumaane versus American, using more versus less conservative measures of what may constitute a deformity. It doesn't really matter. In fact, the results strengthen if you go to using the more conservative estimation. Jumaane women have much higher risk of deformity compared to American women. I'm not going to go into this. We don't have that much time left. If we do the same comparison for men, you basically see a very similar result. In fact, you see a much stronger difference. Jumaane men have much higher risk of vertebral deformity than American men. So this is despite the fact that there were no population level differences in bone mineral density. We see a much higher risk of vertebral deformity among Jumaane men. So whether this is the result of fragility fracture or whether this is the result of traumatic fracture, this is something that we can't tease apart yet. We don't know what the cause of the specific vertebral deformities are, but it's something that we want to continue investigating. I suspect it's more likely due to trauma, at least specifically with the case for men, more likely the case for trauma as opposed to just fragile bone. Okay, so just you have an overwhelming force, for example, from carrying something on the back, whether it's hunted game or 50-kilo bags of rice or other things like this, that's contributing to the vertebral deformities. All right. And I just want to briefly describe some new initiatives that we're doing. So we'd like to continue investigating whether, in fact, we see these structural adaptations to age-related bone loss among the Jumaane, so in these physically active populations, overcoming some of the study limitations that we see in bioarchaeology, just looking at competitive athletes or non-human models. And so what we're currently testing whether greater physical activity levels earlier in life are leading to greater bone strength using peripheral quantitative computed tomography. And so we're going to begin this project in a couple weeks, where we're doing in-village sampling of people's physical activity, so using a combination of accelerometry, GPS, focal follows, heart rate monitoring, and other things like this to actually see what it is that people are doing. This is year one of this project. And then in year two, assuming we can pass Bolivian customs and get this machine into the country, we actually want to do computed tomographic scanning of both lower and upper limbs. And so tibia, femur, radius, humerus, in a population representative sample of 720 individuals throughout the life course. Of course, the same individuals for whom we're monitoring their physical activity levels early in life, and we're coupled with some interviews to try to assess retroactively how physically active they were as children, although this is quite difficult, as you can imagine, but one can try to get at whether folks had labor-saving technology, whether they went to school as children, other things like this to try to proxy physical activity levels earlier in life. And again, trying to look at moderators of the relationship between physical activity level and bone stiffness, looking at age, female sex, energy limitation, pathogen burden, etc. And so we're basically wanting to know whether the transition both from hunting and gathering to agriculture, but also the transition to modernity, urbanization, how this is affecting Jumaane bone structure. And if all goes well, we can then use these same methods and try to employ them in other populations. So actually, if anybody's interested in these types of questions or in these types of data, please contact me, or I'd be thrilled to talk to you. We're still looking for people who are interested in doing field work and gaining techniques in bioimaging, but that's enough advertising I'm going to do for the project. So I think I only have a couple of minutes, maybe to allow some time for questions. But just to conclude, we see age-related bone loss, not unique to humans. We see it in other great apes, but it appears to be a much bigger contributor to human morbidity. Right? We see bone loss in other species, in other primates, but the bone loss is not really linked to fracture risk, whereas in humans it clearly is. And osteoporotic-related fracture may, in fact, be unique to humans. We still don't have any examples, to my knowledge anyway, from wild or captive chimps or other apes. Obviously, appropriate mechanical stimuli are required to maximize peak bone strengths, but from our recent research, simple predictions of these traditional models of bone functional adaptation aren't always supported, and so this begs the need for considering additional mediators and moderators of this relationship between PALs and bone stiffness. Osteoporosis may be a mismatched disease. We're lacking really good data from hunter and gatherers, systematic population level data to try to assess how common was osteoporosis. I don't think we really know. If the Jumaane data are perhaps indicative, it actually suggests that we may have extremely high rates of deformity, vertebral deformity, and perhaps osteoporotic-related fracture in physically active subsistence populations, but those effects could be for other factors unrelated to physical activity, things like high fertility, high levels of infection and inflammation, low calcium intake, et cetera, et cetera, et cetera. But osteoporosis is not an inevitable aspect of aging. And as I was saying before, there's a high growing burden of osteoporosis, yet most focus is actually on treatment rather than prevention, even though there's much emphasis on trying to maximize physical activity early in life to then maximize peak bone mass later in life. And I think that's all I have for today. Yeah. So thank you, everybody, for attending, for the generous invitation. And, of course, thanks to wonderful colleagues like Ben and the entire Jumaane Life History Project. Thanks.
Thank you very much, John. So I think we have time for a couple of quick questions.
So, Jonathan, you showed us a graph early on that had started with hunter-gatherers and ended up with modern people, and it showed a decline with agriculture and then no decline with urban life, basically.
This one?
There was another one too.
So the Neolithic.
Yeah. So I mean, the Mesolithic Neolithic it's a big world, right? So where are these people? Where are these sites? I mean, very recent could be anything from, hardworking farmers someplace in, Central Africa to, me sitting around in front of my computer. And,
yeah.
And that's also true as you go back. And this seems to me to contradict a lot of the other things you showed us, because this suggests that there's a big difference between hunting and gathering and farming, and you don't see any of that in your actual data.
Yeah, I absolutely agree. No, I think if anything, this talk raises more questions than it answers. But specifically to answer your question, this is a fairly large skeletal sample, and it's all from Europe. And these effects that we're seeing are localized effects. They're not systemic in the sense that we don't see similar patterns. There's much more variance if you were to just look at upper limbs. And so this is why I think bioarchaeologists place a lot of emphasis on mobility specifically, which should affect lower limb much more than upper limb. Some of it is speculative and conjectural. But if in fact the changes are systemic, we should expect them in both lower and upper limb. And so, it's things like infectious burden, it's things like famine, so poor diet. These things, these are lifestyle aspects that should result in more systemic skeletal effects, as opposed to something like physical activity, which should be reflected in more localized, so lower limb. But yeah, I agree with what you said in terms of contradictory patterns.
And then just one final question.
I get the last one. Okay. Sorry, I got kind of lost. What was the conclusion about the relationship between osteoporosis, parity, American women, Jumaane women, under 18 and over 18, having had children. I got a little confused. Like,
Well, sorry about that. To be clear, we're not looking at, among American women, we're not looking at any effects of parity on bone structure. The parity effects are limited to only Jumaane. So high parity Jumaane women have reduced bone stiffness. The comparisons that we were doing between Jumaane and American is just looking at bone stiff indicators of bone rigidity or stiffness itself. That's only within population.
Okay.
Yes. Yeah.
Okay.
Unfortunately, we're out of time for questions, but we do have tea time after this. So any additional questions, you can ask John directly then. Thank you all so much.
Thank you. Thanks.